Atrial rhythms. So atrial rhythms are fast. Or sorry, the atrial rhythms are something wrong in the atria. Okay? We'll talk about fast atrial rhythms, and those are supraventricular or atrial, which is another word for atrial tachycardias, supraventricular tachycardias. That's coming next, right? We'll talk about SVTs at the end of this section, all right? First, we have AFib and a flutter. All right, remember your groups because we'll come back for the next after atrial rhythms. There's another little session, okay? So anyways, we got atrial rhythms, all right? So AFib or A flutter, they're very, very similar. All right, we'll show you the differences, but there's controlled rate, which is 60 to 100, so that makes sense, 60 to 100, and we have slow rates or slow ventricular response, all right? That's SVR. And then we have rapid ventricular response, which is a fast heart rate, greater than 100, okay? And if we're greater than 100, rapid ventricular response, you're pretty much now in SVT territory, right? SVT is like an umbrella term that we'll talk about more. It's any rhythm that's fast that comes from the atria is supraventricular. Supra meaning on top of, right? So you can have AFib, A flutter that has rapid ventricular response, or you could have PSVT. Okay, there are other ones out there, and you're not being tested on those. So please don't learn AV nodal reentrant tachycardias, or Wolff-Parkinson-White's, or multifocal atrial tachycardias. Those are not ones we're going to be learning. Okay, there's enough rhythms for you to understand, all right? So the rhythm you have to know: sinus rhythm, sinus brady, sinus tach, AFib, A flutter, whether they be slow or fast, and then paroxysmal SVT. And the last rhythms we want to know before the AV blocks are your ventricular rhythms, which are lethal. So it's important you know your lethal rhythms. Okay, so AFib. So AFib, again, can be controlled. The rate is 60 to 100. How do I know that's 60 to 100? Do I line it up? Do I go, okay, that lines up, and with 300, 150? No, that doesn't work. So it's irregular, right? That's a clue that you have AFib. If someone says they have an irregular heart rate, 8.5 times out of 10, it's probably AFib. That's very, very common, okay? Most common arrhythmia, 3 million in the United States. So how do you know they have rate controlled, 60 to 100 beats per minute? Count the R waves, not the P waves, because there's no P waves in AFib. All right, so you count the R waves, which are 1, 2, 3, 4, 5, 6, 7, 8, 9, right? 9 times what? 30, 300, 75? What is it, 9 times 10? So the heart rate is 90. So 60 to 100 is AFib that is controlled. And that's your whole point with AFib. We used to try, for like the last 50 years, try to knock them out of AFib. It's like, we're going to shock you out of it. We're going to give you medications to change it. But that's like 70% of the time you just go right back into AFib. It's not worth it. It's not fun for the patient to get shocked either. Okay, so all we do is give them medications to lower their heart rate, right? And why was their heart rate high in the first place? Was because every single one of these different atrial activities, these ectopic sites, were getting conducted down the AV node. So if we give them an AV node suppression agent, right, that's going to suppress the amount of impulses they get through and control the rate. If the rate's not controlled, that means every little impulse is getting through, and every little QRS is the ventricle impulse getting through, and then we're going to have a fast heart rate, right? And if their heart rate's greater than 100 and they have AFib, it's called AFib RVR, all right? AFib RVR is just a AFib that is rapid, that is greater than 100. Just like sinus tachycardia is kind of the equivalent to that, right? But how do you know if it's sinus or AFib? One has fib waves and one has P waves. And what the heck's a fib wave? It's just something you can't really discern as a P wave, right? It's just fibrillatory activity. It's shaking. Fibrillation just means shaking, right? So we've lost the atrial kick. So your atria, 20% of your cardiac output is just your atria doing that last little kick right before the valves close and it's time for systole, right? So the atria kick and push all the blood it has down into the ventricles. So for atrial fibrillating, there's no kick. So we all of a sudden lose 20% of our cardiac output. We lose 20% of our BP, right? And if someone is really reliant on that BP and the BP is like 95 and they have CHF, that atrial kick can be the difference between someone that's symptomatic and not symptomatic, right? So that little atrial kick is especially important to a CHF patient, right? So what are some characteristics of how do you know someone has a AFib? Again, they have quivering, shaking atria, not ventricles. That's ventricular fibrillation. We're talking about atrial fibrillation, right? The atria are fibrillating, and therefore we don't get a nice P wave, right? We get a P wave from many, many different areas, and that's going to be, and they're not organized in any kind of fashion. It's like how we decided on groups earlier, right? That is a fibrillation event, right? So our atrial are fibrillating, and therefore you're going to see little little activity, but it's not organized. So unorganized fibrillatory waves are a characteristic of AFib. There's that plus the irregularity. So those two things together tell you have AFib. And of course, you have some QRS complexes as well. Okay, so no PR interval. You can't measure a PR interval because there's no P wave to measure from, right? Like which one of those fibrillatory waves do you start from? Do I start from this one or this one or this one or that one? You can't, right? You can't measure PR intervals in these ones. Okay, so there's different types of AFib. There's paroxysmal, which means just comes and goes. All of a sudden they go into AFib and they come out of it, all right? 50% of the time just it resolves on its own. The other 50% time they are stuck with AFib until the underlying cause is fixed. And what causes AFib is someone's atria that are messed up. They have scar tissue. They have a big atria. So this patient has left atrial enlargement, right? So this guy is trying to depolarize the AV node, but then this guy's away from me, and away from me, away from me, away from me. And now you have 5 different ectopic sites, and now you have AFib on your hands, right? This person is not going to be paroxysmal. That's not something you can fix right away, right? But there can be chronic AFib. When you talk about someone who has chronic pain, it's usually like 3 months, 6 months of pain. Someone has chronic, they have a different chronic disorder. It's usually after a long period of time. Before AFib, 2 days. You got 2 days AFib, you have chronic AFib, right? And that's key because you have to get treatment for chronic AFib. Okay? You can't just live your life with AFib, otherwise you're going to live your life with a stroke, bedbound, right? So you have to get the AFib fixed, right? And how do you fix it? Well, we don't want the heart rate to get too fast, because if the heart rate's too fast, your heart chambers can't fill up, and now you got chest pain, shortness of breath, hypotension, confusion, right, as a symptom. But the other complication of chronic AFib, of AFib that lasts more than 2 days, is what? A blood clot that develops. Why do you get a blood clot? Well, this chamber is not able to pump the blood forward. It's just blood that is stagnant, and blood that's stagnant has nothing better than to hook up with its mates. So it just hooks up with its mates and says, what are you doing? Nothing. Let's coagulate. Okay, cool. And they coagulate, right? And they form a huge clot. And now that clot might make its way down and get pumped out to the brain, or make its way down and pumped out to the lungs, right? Causing an embolism, right? A clot that gets made is called a thrombus, and a clot that's traveling is called a what? An embolus, right? So you get a pulmonary embolus. You get a mesenteric embolus. So where's that going? Going to the gut, causing abdominal pain and bowel death. It could go to the arm. It could go to the leg. It could go to the brain, right? When you have AFib, you have 17 times more likely to get a stroke than someone who does not have AFib, okay? So if someone has AFib that's more than 2 days, do they have to get what medication? You have to get an anticoagulant to stop the atria, stop the blood from coagulating, okay? All right, and then sometimes they can come out of it, but if they don't come out of it, it's called permanent AFib. All right, so the causes of AFib is abnormal atria, physically. The atria are big. There's a structural change of some sort. There's an MI, or there's hypertrophy, hypertension. If this ventricle is working super hard down here, there we go. All right, this ventricle, sort of. I guess I can't draw anymore. Oh, that's sad. All right, so if that ventricle down there is working super hard, that left atrium is also going to work super hard. All right, this guy's with hypertension is working hard for 70 years, 50 years. Now it's going to start getting hypertrophied, and now this atrium is going to have to work extra hard, and it might get dilated. And now you have AFib on your hands, right? So that's the idea behind AFib. There's a structural irregularity. There can be scar tissue. There can be something, a valve disease. There can be a valve that's stenosed, really tight, and now that left atrium is going to balloon out, or the right atrium might balloon out. Yes?
If you have ventricular hypertrophy, do you always have atrial enlargement?
Not always. It can be a complication of it. Yeah. All right, so dilation, again, MI, CHF, valve disease, all these things are interrelated. When we talk about cardiac, it's going to sound like I'm repeating myself so many times because it's all interrelated. One thing leads to another, leads to another, leads to another, and it's all going to end up causing complications, right? One of the complications is AFib, okay? So what else? So irritants, what causes someone to go into AFib or go into AFib RVR? Well, A, they have to have a structural irregularity, and B, they have to have some of these factors that the SNS got stimulated by, right? So they have low O2, they have low pH, high CO2, low blood sugar, they have fever, infection, stress, nursing school. All these things are going to throw you into AFib, right? And hypoglycemia I mentioned as well, all right? And sometimes it's just unknown. We don't know exactly what it is. They could have an abnormal conduction system. It could be genetic, it could be something going on. They have to go to a special doctor that looks at just the EKG system of the heart. Not a cardiologist, but an electrophysiologist, okay? So what's the treatment for AFib? Well, this is also kind of the ABCs, so don't get confused in the ABCs. Part of the ABCs here is the ABCs that we talked about before. Someone has too fast of a heart rate, we gotta bring it down, and that's our ABCs we're used to, right? ABCD, all those medications are AV node suppression agents. All those agents are gonna bring the heart rate down to 60 to 100, right? Like we've talked about. But the other thing we do for AFib is we're going to expand our ABCs, and we are going to do A for anticoagulation. We have to anticoagulate them if they have AFib for greater than how many days? Greater than 2 days, right? If they have a history of AFib and they come to the hospital and they didn't take their meds because they're sick and they're older and now they're in your care, it's like, oh, what kind of history do you have? AFib? Well, shoot, we got to start you on your medication for AFib, right? Medication being rate control, right? And also anticoagulation. Right? The patients get sent home on this medication if their AFib is not fixed, right? And they have to continue that medication until their AFib is cleared up, okay? Sometimes the doctors have crazy ideas and they'll try to shock them out of the AFib, but the AFib will just return like 7 times out of 10, okay? So that's not really the fix for it, all right? But you'll notice that we do have D for direct cardioversion or synchronized cardioversion. And that's usually when they are symptomatic, when their AFib is way too fast. And it's causing problems, it's causing what kind, how do you know that it's too fast? How do you know the patient's symptomatic? They have chest pain, shortness of breath, hypotension is the key, right? They could have chest pain, shortness of breath, confusion. You might just try to give them some medications. Give them metoprolol, right? Give them diltiazem, give them digoxin to lower the heart rate. And that might just be just enough to allow their chambers to fill and allow them to perfuse their body, right? But as soon as they get hypotensive, all those drugs are off the table. Oh, but I can give digoxin. Well, no, really, really at that point, it's time to shock them out of the rhythm, right? It's really a aggressive way to restart the heart, right? Adenosine will just, shut the heart down and restart it, but that's only given for PSVT, not for AFib, okay? So anticoagulation, what kind of anticoag meds? Again, we'll study more anticoagulation meds for exam 2 with cardiac. But these guys will come back at that point. Usually they start 10A inhibitors. So apixaban, they all have 10A in the name, which is nice. All right. So it used to be warfarin, but warfarin was developed in the 40s as a rat poison, and we decided to give it to humans for 40 years or 60 years, and now we're more cultured. And now we have 10A inhibitors. Okay. The complication rate because it killed rats by causing them to bleed in their brains, but also humans bled in their brains too, and that was one of the risk versus benefits we had because we had nothing else. But now we have 10A inhibitors. And those are the medications that should be there because we want to stop the risk of forming clots, which is a thrombus, from traveling. So it can be formed in the heart here and it can make its way to the brain, causing a stroke. For exam 3, we'll go over BFAST and all the symptoms of stroke. Okay? So our goal with the AFib is to make sure they're anticoagulated if it's persistent, bring down the heart rate, and all these ABCD drugs are making sure you hold the door, right? Making sure you are stopping the impulses from getting through. All these impulses want to come through the AV node, but now we got to help a brother out, and we got to give him some support, right? Give him digoxin, give him a beta blocker, give him something, okay? And then we can go to a electrophysiologist, and we can do C, which is catheter ablation. They can find the spot that is causing the AFib, and they go in there with a little probe, and they cook it out. They just cook it at 95 degrees, and they scar it up, and they stop that ectopic site from going off, right? Usually it's around the valves. That's usually the most common site where they can ablate the ectopic site, Okay, and then we have direct current electrical cardioversion, that's DCCV, or synchronized cardioversion. Synchronized means that we want to make sure we look at the R waves and we don't shock them in the T wave. Do people with AFib have T waves? Yes, they do. There's always a QRS and a T wave of the ventricles repolarizing, right? But there is no P wave activity, right? Or there is, it's just fibrillatory. Okay? Sometimes it's so fine that you can't even see it. It just looks like a solid line. All right? But you know that's irregular and there's no P wave, it's probably AFib. All right, so if they have no symptoms, right? They don't have chest pain, they don't have shortness of breath, there's really no purpose of doing this anymore. Okay? All right, so that's the idea behind AFib. So cardioversion. So this kind of requires a table in itself so you don't get confused, so you know exactly which one is which patient gets shocked, which patient doesn't get shocked. But when we talk about cardioversion for fast rhythms that have a pulse, it's always synchronized. If they don't have a pulse, we don't care. They're already dead. It doesn't care if they matter if they go into a lethal rhythm like torsades. We're just shocking them out of this rhythm that's causing them to be dead, and we don't care. Right? But if someone has a pulse, they're talking to you, it's like, okay, I'm going to give you some sedation because this is going to hurt, right? So I'm going to give you some sedation. You have to sign consent because this is going to hurt, right? And the risk is that we might shock you on the wrong thing because the nurse might not have hit the sync button, right? So because if they hit the sync button right here on this machine, the sync button is right there. This is called a Zoll, by the way, and it's a very popular device. There are other brands of defibrillators. But the Zoll defibrillator, or the defibrillator, is going to shock them out of that rhythm. How does it shock them out of that rhythm? First, the nurse hits the sync button so that you can see it's detecting the R waves. And why do you want to detect the R waves? So you don't shock them on the what? On the T wave. If you shock them on the T wave, they're going to go into what lethal rhythm? Torsades. So if someone has a pulse, it's always synchronized, right? If there's no pulse, you can shock them whenever. It doesn't matter. They're already dead, right? So what else? So they need consent for this. They need to also be sedated for this because it hurts and you can die from it, right? So it's important they know their risk versus benefits and they know what's there and what the what the alternative is. And really the alternative is if you're not symptomatic, you really don't need this. Okay? You should go for a catheter ablation instead. That works. Okay? So indications for synchronized cardioversion in general is yes, fast AFib, fast A-flutter, but also a really fast tachyarrhythmia. So a rhythm that's super fast, that's not letting the chambers fill up with blood, and therefore they're getting chest pain, shortness of breath. The key one is hypotension. If the blood pressure is less than 90, we can't give rate control medications anymore. All those medications have what side effect? Low heart rate, right? Sorry, yes, low heart, that's what you give for. Low blood pressure, okay? And then, so AFib, A-flutter that's fast. We got SVT, VTAC with a pulse. Can be shocked if they have a pulse, and then SVT as well. Okay. Sometimes sinus tachycardias, if you've tried everything else, you tried to fix the underlying cause. Sometimes. Okay. So again, meds cannot be given that we would normally give because all of them lower the blood pressure less than 90. Yes, digoxin, you can try it, and if the blood pressure is borderline, but again, if the blood pressure is like super low, like 60/20 blood pressure, you're not going to do digoxin. Okay. All right, this is different from defibrillation, which is just a word people throw around to say that means unsynchronized cardioversion. That's what you do for lethal rhythms. If someone has a rhythm that's perfusing their brain and perfusing and causing and allowing them to be awake with a pulse, we do synchronized cardioversion. Okay, so there's synchronized cardioversion and unsynchronized cardioversion. When we talk about ventricular rhythms in a little bit, we're also going to show you a difference between the two. So you can, because it can be confusing.
How you doing, Bill? All right, I think Bill's asleep.
Example of cardioversion.
Okay,
here.
let's go ahead and get going. Okay, we're about to start here. I wouldn't touch him, actually.
So you got
Everyone
sedation,
clear?
consented.
All right. Go ahead.
So he's confused.
Okay, hold it down.
There it is. Oh. 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 Oh.
All right, so he might need another shock, but he's not going to remember this because usually sedation has amnesia effects. So they're not going to remember that, which is nice. Sometimes you don't have the opportunity to give those medications because the blood pressure is too low. Every sedation medication ever lowers your blood pressure. There's not one that raises it. All right, so A-flutter, and then we'll take a break. So A-flutter is just like AFib, same treatment, same things, same ABCD, same rate controlling medications, same risk for clots, all the same things, except sometimes it has a feature that you can see those ectopic sites. Before we had fibrillatory waves, you really couldn't tell what was going on. You just knew there's a lot of ectopy throughout all the atria, a lot of extra sites that were causing problems, right? But with A-flutter, it has an organized capacity. I would like to see when we say that when we just define groups, we had A-flutter. There was some kind of organization to that to figure out who would be in what group, right? Before you gave the answer for the EKG, which was the QRS complex, right? So sometimes it is organized, meaning that it's like an organized rhythm, or sorry, I should say a regular rhythm, where it has a pattern to it. It has 3 F waves, which are flutter waves. Atrial flutter is the only rhythm that has F waves. So you have flutter waves here. You see you have 3 there, 3 there, 3 there. Sometimes like that for a long time, 3, 3, 3, 3, 3, all the way through. Sometimes it goes back and forth, 3, 2, 3, 2, 3, 2. Sometimes it has no pattern, 3, 2, 5, 1. I can't do pi, 3.416. And it has its own little. It's irregular, right? And another cute thing that people do when they electrophysiologists when they're bored, what they do is they describe rhythms as irregular. It's like, yeah, I understand it's irregular, but is it irregularly irregular, right? Or is it regularly irregular? So what that means is that it's irregular. I understand that, but is there regularity to the irregularity, right? So if it's 3, 2, 3, 2, 3, 2, 3, 2, that's irregular, but it's regular. It's regularly irregular, right? But if it's 3, 5, 3.146.2, whatever, that is irregularly irregular. AFib is irregularly irregular as well, because there's no regularity to its irregularity. It makes no sense, but just an FY. I'm not going to test you on that. Don't worry. Okay, but the causes are the same, so it's nice when you're doing a table right here. Ditto. That's it. The only difference is I have F waves. I have flutter, right? So you have to recognize, oh, that's a flutter. Why there's so many P waves there? Those aren't P waves. Those are flutter waves. Well, how do I know it's a flutter wave? It has a little more sawtooth appearance to it, a little more teeth-like, right, compared to a regular P wave, which is nice, upright, and rounded, right? So that's a flutter, and this is an example of differentiating them. If you have to play this video 12 times, I won't judge you. The little asterisk there is sometimes a flutter can also be irregular. Okay. All right, I think that's it for atrial. Then we'll come back and talk about supraventricular tachycardias.
Look at him go.
All right, so supraventricular tachycardias. So SVT and VT are 2 different things. So SVT means it comes above the atrium, or supra to the atrium, supra to the ventricle. Supraventricular is above the ventricles, whereas ventricular tachycardia is the ventricles are going way too fast, right? So ventricular tachycardias fall under our ventricular rhythms. We talk about ventricular rhythms. VT is one of them, right? We're still up in atrial rhythms, and we're talking about SVT. Okay, so supraventricular tachycardia is just an umbrella term. SVT used to mean just one specific rhythm, which was PSVT, but now it's been downgraded. PSVT is a type of SVT. Okay, so the rhythms you have to know are AFib, A-flutter for atrial. You have to know PSVT, and you have to know, of course, rapid and rapid AFib, rapid A-flutter. You don't have to know about actually proximal SVT. Sorry. Oh no, sorry. There we go. So all you got to know is rapid AFib A-flutter, which is just a AFib A-flutter greater than how many beats per minute? Greater than 100. Right. So we're 2/3 of the way there. The other SVT that we have is proximal atrial tachycardia. So it's going to be a fast atrial rhythm that is paroxysmal, and we'll describe what that looks like. Okay. So what else on this? Technically, sinus tachycardia is an SVT. It came from both the ventricles, and it's fast, right? But we don't typically group it into that category. All right, so unfortunately my mic died, so I got to carry this with me a little bit closer so you can hear me as well. So supraventricular tachycardias, again, they can be sinus tach, they can be paroxysmal SVT, which just means that we have a really, really fast heart rate that's coming from the AV node itself, right there at the AV node. It's not really higher where we can see P waves, so therefore there's no P waves for PSVT. All right, that's kind of the only difference between ST and PSVT is one has P waves, one doesn't, right? And also PSVT usually is a lot faster. It's usually more than 150, usually it's up to like 220. It's a really, really fast heart rate, right? So when someone has a heart rate of 200, it's like, do they have PSVT? That's usually what it is. And also it's narrow, because if it was wide, it might be VTAC. Remember we had the little asterisk, so sometimes SVTs can have wide complexes, okay? The other unique thing about PSVT is it's the only arrhythmia that we can use non-pharmacological interventions for. We can do things that are not medication-based, not shocking-based. We're going to shock them out of it. We can do things to the patient to take them out of that rhythm. No other rhythm you can do that, right? So PSVT on the next page will talk about those non-pharmacological things you can do for the patient, right? So AFib, flutter, we talked about as well as the previous section. And if that heart rate is greater than 100, that is a SVT, not a PSVT, but a SVT, a supraventricular tachycardia, right? And then we have just FY, we're not going to test you on these, but it's unfortunate that wandering atrial pacemaker is no longer, WAP does not mean wandering atrial pacemaker anymore since like 2020. So once a WAP is faster, that's called a multifocal atrial tachycardia. So sometimes you can tell the P waves, they're coming from different parts of the atria. It's not so much a flutter yet, but you can see with each P wave, it looks different. Like, why is that P wave upright? Why is that P wave down? Why is that P wave going above and below? Okay, and that happens to be faster. It's called multifocal atrial tachycardias. And there's AV nodal re-entry tachycardias. Just if you look at other sources and other books, you can skip over those sections. That's just why I'm pointed out here. Okay, all right. So the treatment for these guys, all SVTs, is ABCD drugs. So you want to lower the heart rate because it's fast, right? The only exception is we can do non-pharmacological. So the key piece for all disease processes is always do non-pharmacological first. Diet and exercise is a good answer, but that's not going to fix this. But you're going to be doing anything non-pharmacological you can do, and then we do pharmacological, then you do surgical, and you might do some other more invasive things. It's always least invasive to most invasive. That's just how things work, right? So the only one of these rhythms that you can do non-pharmacological things for is PSVT. All right, so SVT treatment, or I should say PSVT specifically. All right, so PSVT. So PSVT, if their blood pressure is greater than 90, right? So that means their blood pressure is good, but they have this really, really fast rhythm. What are they to complain of? They have a really fast heart rate. It's got palpitations. My heart is racing, right? So you can tell, and then if you look at that, look at the EKG, you say, well, your blood pressure is good, but I understand you have some chest pain and some shortness of breath, and you might be a little bit confused right now. You can't really say your words, but let's go ahead and do some maneuvers. Let's do some vagal maneuvers. All right, these vagal maneuvers are non-pharmacological things we can do to the patient to fix their fast heart rate. Because we did an EKG, we saw, oh, they're an SVT. The heart rate is 200. There's no P waves. That is paroxysmal SVT. And we can fix that by stimulating the vagus nerve. What does the vagus nerve do? It's going to go to the SA node and AV node and suppress it, right? So it's a non-pharmacological way to fix a fast heart rate, right? So you can exhale, so you can go into the room and say, okay, exhale against a closed glottis. Closed glottis, exhale against it. What does that mean to the patient, right? So you have to be able to, give them instructions. And what that means, you might be blowing through a syringe, right? The smaller the better, that's more resistance, right? So they're exhaling against a closed glottis. So it's like, pretend like you're defecating. What does defecating mean? I don't know. So you have to, you can this is the easiest thing, is to grab a syringe, okay? The best thing, the one that works better though, than just blowing through a syringe, is what's called the modified Valsalva, where they blow through the syringe and then you tip grandpa upside down, all right? So you go ahead and say, blow through the syringe, and say, okay, whoa, and you're going to tip grandpa upside down, okay? So this is an example of that. So you see, look at the heart rate up there is 214. So heart rate's 214 back there. It's like, come on, grandpa, you got this, right? So he blew through the syringe, and then he breaks the SVT there. And they're going to go grab 2 nurses to have him hold him like that. I'm kidding.
While they're like this, do they have to still blow through the syringe? Or?
Yeah, they blow through the syringe first, right there, and then they tip him over.
Figured that out.
Somebody dropped a patient somewhere.
So I put this on a loop, but unfortunately I cannot turn it off. Hold on. All right, so that's what you do for a modified Valsalva. They blow out through the syringe, and then you flip them upside down. All right? And then another thing you can do is carotid sinus massage. Right, so the carotid sinus is right here by the carotids, by the neck, and then they just massage it. But you got to make sure they're less than 45 years old, otherwise you could have plaques there and you can cause a stroke, right? So you got to make sure they're 45 years of age or younger, and then if you can listen first to make sure there's no occlusion, because you don't want all that plaque to dislodge and make its way up to the brain. Okay, and then it wasn't until the year 2000 until the American Heart Association took out the recommendation to do a circumferential DRE, which is a digital rectal exam, right? So you flip the guy upside down, it's like, whoa, what's that? Or so they say, it's almost cold gloved finger was the recommendation until the year 2000, for like 30 years. It's like, okay, we're going to be circling and doing that guy, all right? Back in Japan, that's a pastime for the young school kids. They do concho, and they go, and that's supposed to be a cool thing. In America, it's called sexual harassment, all right? But if all that stuff doesn't work, then the next thing is pharmacological, right? So we try non-pharmacological first, and then non-pharmacological, and then pharmacological, right? So after concho doesn't work, then pharmacological. So I skipped it. I can't go back, unfortunately, otherwise I lose all the audio. But on the bottom left, on the bottom of the screen, it shows the echo of someone's heart, and they get the adenosine, and then it just stops, and then it reboots. Okay. So what was I going to say about that as well? So adenosine, again, it lasts for 8 seconds, and you have to give it super fast, all right? So how to give adenosine? Just know you have to give it fast. You will give it practice-wise in MedSurg 3, not this course, okay?
That's a good guess.
It's designed that way. Yeah.
Okay.
To be suspicious.
Okay.
All right, number 1. Who's number 1? All right, what is number 1? Yeah, it could be fine, AFib fine. All right, so the reason why it is AFib is because A, it's irregular. You got irregularities in these intervals here, and you really can't see the fibrillatory waves, but if you had to guess, this is AFib. When next semester we learn about junctional rhythms, they don't have P waves either, but junctional rhythms are regular, so that's one of the ways we can tell the difference. But if you have an irregular rhythm, it's probably AFib, all right? All right, next one.
We put AFib with RVR.
I didn't ask if it was controlled or slow ventricular response or rapid. So the first one, actually going back, how many complexes we got?
80.
Got a rate of 80, so that is
Controlled.
So probably add controlled there. All right, controlled. Okay, and then the next one is what?
AFib with rapid ventricular response.
Good. AFib, RVR. AFib with rapid ventricular response. And what's the cause of AFib, RVRs?
Chronic AFib with fever.
Yeah, you could have chronic AFib. And then you have something that someone has structural disease, someone has a problem with their heart's structure. You got dilation or hypertrophy or scar tissue, and they have some SNS response, right? It could be meth to a actual SNS response, right? Or they have anxiety or fever, etc. Okay. All right, number 3.
We put course AFib with RVR.
Yeah, you could argue it's AFib. I mean, it looks like it's trying to go into a flutter, but yeah, it's not. It's unorganized. It's not nice and neat like flutter. Like the next one, that's perfect flutter right there, right? Those flutter waves. Look at those flutting waves. Anyways, we got lead number 3 is AFib. What? RVR, because it's faster than 100 and it's irregular. That's what clues us in that it's AFib and not sinus, right? You say, oh, that might be sinus rhythm. Look at that fourth complex. It looks like there might be a P wave in QRS, right? But that's just kind of like what somebody says, well, you're trying to argue that the other ones are disputed evidence, okay? All right, and then we got number 4.
A flutter?
Yep, perfect A flutter. And is it slow, regular, or medium? Rare. I'm kidding. Slow, regular, or RVR? So this one is a regular A flutter. So we can use the 300 method here, right? Because it has regularity to it. Okay. Number 5.
PSVT?
So PSVT, yep, I don't see a P wave there with QRS. That little upright complex before the QRS is the T wave still finishing. All right, that's the T wave there. There's no P wave here. No P wave and fast equals PSVT, right? So what can we do to fix that? What's a treatment for that? Concho or Valsalva if we're more cultured, right? I thought we're more cultured than Japan. I'm just saying it's more accepted here to do carotid massage or you can dip someone's face in ice. That'll work too. Okay. It's less frowned upon. And then what else? We got so the causes of PSVT. It could be some ectopic site. It could be something that's causing a rapid response like that, which would be what? Something SNS related, such as variant fever. What's another one? Got it. We said infection. Anxiety. All right. All right. Next one. What's number 6?
A flutter?
Looks like a flutter, and it's irregular. There's not really a pattern to that. Okay. So is it fast or slow? If that's a 6-second strip, looks a little that fast, right? 3, 5, 6, 7, 8, 9, 10, 11, 12. So A flutter at a rate of 120. So that's A flutter RVR. Okay. All right, and next one, what's that? Yeah, it's a little bit tricky. And again, on the test, it'd be very clear. And on the quiz, it'd be very clear if it's A flutter or not. But this looks like the end of the T wave. The T wave is kind of biphasic. Okay, it has an up and a down part to it, right? So that would make it what? Yeah, so I would argue this is probably PSVT, but I'd also argue that we should get a 12 lead, and that would really tell us which one it is. Okay, and number 8, that looks regular or irregular? Looks irregular, so you can bet money at Vegas that it is AFib, not A flutter. A flutter, you can see F waves, right? Or sawtooth waves. AFib, you can't. It could be really, really fine. AFib. If you switch the leads to different lead, you might be able to see those fibrillatory waves. So is it AFib RVR, AFib SVR, AFib normal? What is it? So it's faster than 100, right? And what's the cause of that? And also, you got a little extra flavor there too. It's extra side of meatballs, right? We got a bundle branch block, right? Because usually supraventricular tachycardias are narrow complex. If they're wide, it could be a bundle branch block, or it could be something lethal. So that's why, doing a 12 lead is important to this patient. Everybody knows what a 12 lead is, right? Versus a 12 lead is a formal test we do, a formal diagnostic test we do to make sure that what we're seeing on the bedside monitor is what we're seeing. Okay. All right, and then next one, number 9.
PSVT.
So PSVT is pointing to something. It's pointing to a little tiny little P wave, I think, buried in the T wave. All right, so basically you don't have P wave QRS. You have maybe it might be a buried P wave, but it's definitely not visible. So that's a PSVT. How can you fix PSVT? You can cardiovert them when? When would you do cardioversion? When the blood pressure is less than 90, right? Adenosine is going to lower the blood pressure. So it's going to stop everything. It's going to stop the heart, and it also vasodilates. That's why they get a flushing sensation when you give adenosine. Okay, so this patient, if they had a low blood pressure, less than 90, we would skip non-pharmacologicals. Like, wait, I'm going to do carotid massage. No, their blood pressure is way too low. You've already skipped all those pieces. Now you can't give medications either because the medication will lower the blood pressure. The next step is what? Is electrical shock of some sort, right? So we have to shock them. And they probably have a pulse here, but if they have a shock and if they have a pulse and we're gonna shock them, what's the button we have to press on the machine? It's synchronized. So it's synchronized cardioversion. All right, and then top left there, number 10. That's A flutter. Well, that looks like sinus tach, but the sawtooth appearance of the flutter wave is what brings us to saying that it's A flutter. And what's the rate on that? It looks pretty regular, so we can use the 300 method. So what is it? So less than 100 or more than 100? It's almost exactly 100, right? So it could be borderline. If again on the exam or the quiz, it'll be very apparent if it's fast or slow. All right, so A flutter 1 to 1. And next one looks like they're trying to flutter. Looks like it could be flutter. Is it flutter or fib? It's hard. I mean, you have to maybe get a 12 lead to see if other leads really corroborate it. I say just AFib. If you have to guess, that's usually the law of averages. Is AFib. If it's irregular, you really can't tell. Like if you're looking at between 11 and 12, definitely 12 is flutter. Like if you really had to write home about something. All right. So number 12 is A flutter. What kind of A flutter? So it's slow ventricular response, right? And does it have regularity to it? It's 1, 2, 3, 4, 5 humps, and then 1, 2, 3, 4, 5, 6, 7 humps. No. Okay. Variable, and it's slow ventricular response. And how do you know it's slow? Well, it's irregular. So what method can I use? The 300 or the 10x method?
10x.
So yeah, 1, 2, 3, 4, 5 times 10 is a rate of 50. Next one.
Yeah, that's 13. That's us. Sorry. I put it as SVT because the rate's above 200 if you use the R to R, but
Yeah, that little hump before the QRS complex, I would not argue that's a P wave. So the P wave sometimes can be buried inside the QRS complex with SVT. So again, on the exam or quiz, it'll be very, very clear. It's not going to be something like, oh, maybe that's it or not. It's this is PSVT because the P wave's not great. It's not a P wave you can write home about. Let's say that that's actually, and again, that's why you do a 12 lead to see is it really this or not. Okay, so the blood pressure is greater than 90 and they have this rhythm. What can you do about it? What would you expect to be done about it? What is that?
give adenosine.
Adenosine. Okay, so adenosine is the drug you give for PSVT, right? Can you give the other drugs? You could, but this is usually short-lived. So usually adenosine is the one you want to reboot the heart. There's been there's been a reentrant thing around the AV node, and it's going haywire, and we got to just reboot the heart. Okay? It's like a blue screen of death. All right, and then number 14.
I struggle with this one a little bit because it could be like a 1-to-1, but in reality, because it's almost at the 300s, it's like 250 to 300s with the R to R because it's regular. I would go the PSVT again. Yeah,
since it's regular, it's probably a supraventricular tachycardia that's probably paroxysmal. And again, like when the heart rate's fast. And we don't know if it's PSVT or A flutter with a 1-to-1 response or all these other fancy things. Sometimes they will give adenosine to slow it down enough so they can see what's going on. Okay. And also T waves are a little peaked. Okay. All right. And then you can see the difference between 14 and 15, right? So 14 is nice and regular, whereas 15 is nice and what?
Irregular.
Irregular, right? It's irregular and fast or slow or controlled?
It's uncontrolled, for sure.
It's uncontrolled, which is what? Slow or fast?
Fast.
Fast, right? So it's a fib or flutter?
Fib.
Fib. Why is it not flutter? I mean, it doesn't have to be the regularity piece. It's just, you have to like have clear sawtooth lines, right? Sawtooth waveforms. Like you can see like in 16, I guess probably not the best example, but either way, it's AFib RVR, right? And then the next one, number 16. So it's like, well, which part of the rhythm to assess? The first half or the back half? The back half is normal. The first half is not. It's a little run of an abnormal rhythm. A little run of what? PSVT. There's no P waves there. That's just a whole huge T wave, right? So we got a run of PSVT, and the rate is pretty fast. Like it's hitting up to like almost 250, right? They're going to feel their heart race. All right, and the last one, or what is this next one? Number 17. We got 17. This happened last time, right? What happened with 17?
It was this. We had it.
There's actually a trick. There's one I'm not going to test you on. All right, notice the P waves are different. Okay? So this one is coming from somewhere else in the atria. It's a wandering atrial pacer. All right, top left, 18. There's definitely some ST segment changes there. See, the ST is elevated here, so normally everything should be baseline, but we got some elevation there, right? What is that? There's not really a P wave there, right? The P wave's not really that great. So what is it? So it's PSVT with ST elevation. What about the next one? That is definitely AFib. Those P waves aren't great. They're also not flutter waves. So it is AFib. What kind of AFib? So is it rate controlled? Yeah, the rate is 70, right? Because there's 7 complexes. So what about the next one, number 20?
A flutter.
Yeah, it's a very, very slow A flutter, right? And then the final, or the bottom left there,
AFib.
that is AFib. You can see the difference between that slow A flutter and a slow AFib, right? Fib literally has fibrillatory waves. You can't really ascertain that they have any kind of organization. Just like comparing 22 and 23. They're both RVRs. Which one's AFib, which one's A flutter? So 22 is AFib because it's irregular. That's a really big clue, but the other big clue is the flutter waves. That's the other sawtooth appearance. Compared to 24 is just regular old sinus tach, right? Because those aren't flutter waves. Those are just, that's a regular P wave.
Is 22 regular?
Regular? Yeah, I would argue, I would say that more AFib than anything. Yeah, let's change that. Because there's maybe you can say a little run right there.
Yeah.
But let's just put that AFib. AFib RVR. All right, and then next one, 25. A flutter. That's a nice, clear flutter waves. And it looks a little bit slow, but is it more than 60?
Yeah.
It's 70, right? So it's rate controlled. And the last one is worrisome because the QRS is prolonged. So anytime you have a wide complex tachycardia, we always say it's ventricular tachycardia until proven otherwise. So how do you prove it otherwise? You have to go do a full 12 lead EKG to see if that is a SVT or it is a VT, right? And that's the segue to the next session for ventricular tachycardias.